All right, Bill, good to see you, man. I know today we're doing a lot of breast surgery, so I figured that, in our kind of quest to really achieve the best result and best outcome for our patients, I really wanted people to understand kind of how things have changed. When you think about the ideal aesthetic result for a breast, what is that, and has that changed in your career so far?
Yeah, I mean, I think initially when we first started out, patients wanted these big, enormous, kind of fake looking breasts. And I think we've sort of gone down this road now of wanting a little bit more natural of a result. But I tend to tell, patients, and I think you do the same, is we really want to tailor it to exactly what they're looking for. Sometimes people want to have that fake look,
Right.
and sometimes they want a natural look, but when they say natural, sometimes they mean fake. So it's really trying to figure out exactly what they want. And the good news, we have options, right? With
Right.
fat grafting, implants, different types of implants, different placements of implants, we can really tailor that look. But the problem is we need to find out exactly what they want.
How do you find out exactly what a patient wants? I mean, is that something you can figure out instantaneously with that patient, or what are some of the things that patients can do to understand what they want?
Luckily, we have the experience, right? And we can sort of hear what they're saying.
Right.
So that gives us a little help. But ideally, the more pictures we can see of what they're looking for really helps. Having them try on implants, because I think that is by far the best way to size a patient. There's all this 3D imaging out there, but I think it's horrible in terms of sizing. Because, I mean, you look at those pictures, and a lot of times they're like, oh, that's not big enough. That's not big enough.
Right.
But in reality, when you put that same implant in a tester and they try them on and look in the mirror, they're like, oh my God, this is overwhelming. This is way too much.
What about when a patient comes in? What we forget and think about is that everything on us is changing every day, and their breasts are always changing. How do you convey to them that, when we approach the breast, it's never a one and done. It's like even when you do a facelift, it's kind of do a facelift and then you maintain and potentially tweak things as you go. It's like preventative or reactive treatment at times. For the breast, is it similar? Is it different? And how do you counsel them now? Because I think we're doing a really great job now of really preparing that patient to know what it means to have something now, 5, 10, 20, 30, 50 years down the road.
Yeah, I mean, I think it's super important to know that the whatever we do, it's not a forever situation. Where you can do a tummy tuck, and if the patient maintains their weight, that results pretty much forever.
Right.
Versus a breast augmentation or an enhancement or a lift, none of that's for forever. We don't have an anti-gravity machine.
Right.
So it's really important to let the patient know that if they go the implant route, they 100% will have to change those implants out at some point in time. We typically say 8 to 10 years, but it could be sooner, it could be later. The other part of it is that there's a gravity effect with what we put in there. And so over time, those soft tissues will stretch.
Right.
Now, luckily, we have new products out on the market that can help prevent that soft tissue stretch over time. I mean, what do you like to use in those circumstances?
Yeah, I think one of the big things to consider is sometimes it's like bigger is not always better. We're learning that.
Yep.
We're also learning about technique, pocket placement. So you can't be a one-trick pony. I think that's what patients need to realize. And it's almost because everybody's appetite's different, like you mentioned. It's like you might like this artist and his piece of work or her piece of work, and I'm like, oh, that is ugly. I would never put that on my wall. I like this one. There's a similar kind of concept with, I think, breast and what people want. But I think, though, that we are learning that smaller is potentially better, and that if somebody wants more volume, we can combine things, right? People are so afraid sometimes of the scars, and I know I'm jumping around, but when you do a lift on somebody, that vertical scar, I know it's there, but it disappears. But the way that it shapes the breast, tremendous amount of value, right?
Yeah, if somebody needs a lift, hands down, do the lift. Don't go towards, I'm going to do a bigger implant.
How often have you seen that? And the patient's like, I don't know why this happened. The doc did this, and it's been so big, and I'm so top heavy. I feel like I'm large. My back hurts.
All the time. They said they were way too big to begin with. We went bigger to try to avoid a lift, and guess what? I still need a lift.
Right.
An implant will not solve the need for a lift. If you need a lift, you got to go get the lift.
And there are instances too where I think, how do you counsel the patient about it's not really finality, but the concept of an implant. When you're going to get an implant, what that actually means, and just making sure they're in for it. Because I think the biggest thing I've found out, it's like even when we built a house recently, I like to know what's coming. I hate getting surprised and having to write a big check for something I wasn't planning for. How do you approach a patient for that? Because I think that's something we're taking very seriously now.
Why I think there's always maintenance.
Right.
You know, people don't really understand the concept of maintenance when it comes to plastic surgery. You have to maintain your results, and you have to invest in the investment that you already made. For implants, you got to go back and see your surgeon. You got to see him on the routine basis, right? You got to make sure everything's okay.
Right.
You got to let patients know that over time they will kind of drop unless you end up putting a mesh product or something in there to kind of help hold them, sustain their level or their position. And then ultimately, you got to let them know that you will end up having to replace these implants. And so when that occurs, and again, typically it's 8 to 10 years, but it can be sooner.
Yeah.
And
And
so
then there's another thing is they may have issues. They may want to get their implants out and maybe even get their capsules out. So I think they just need to know.
Yeah, I mean, this concept of breast implant illness, it's real, and we see it all the time.
Yeah.
And so patients need to be aware that that can occur. Now,
Right.
the incidence is low,
Right.
but it's still out there.
Yeah. And I think it's just that idea of knowing that, these things are there, and then when they're not surprised, they can plan for it. The other thing is, they're going to go through different things in life. I think this is really interesting is that, you think about the phases of a female when they, are children, go through puberty, breasts come and emerge, and everything changes. And then you go through that teenage, 20-year-old age, and then you have children, lactation, engorgement, breasts change again. And then you go through this steady state where there might be a reconfiguring then, and then you go through menopause, and then things can change then also. So there are certain phases where the breasts change, and those may be specific time points to kind of make a subtle adjustment so that you feel good, you like what you see.
And I mean, don't you see that the patient mentality changes as well?
Yeah.
Like where their thought process was when it was 20 versus when they were 40 versus when they were 60.
Right. It is amazing because I think you can do something where you do like a breast enhancement. They're like, oh my God, I love these. And then later on in life, you take care of them, you do an explant and a lift, and they're like, oh my God, I love these. And so, like you said, things change and you need to adjust for those changes. Your favorite type of surgery is what?
I love them all, to
Yeah.
be honest with you. That's
Yeah.
the beauty of plastic surgery is the fact that we can do any and everything.
Yeah. He loves a complex, revisionary case. I think I can safely say that you're such an expert in those, and I think you stand up to the challenge. But what's the reasoning why you like those complex secondary or tertiary revision cases? Why do you really appreciate those? Because I know you do.
I think one, we can help patients. We know that we can help them. They have a distinct problem. They've been dealing with it for an extended period of time, and you take that problem and you fix it.
Right.
But it's also a challenge, right? Like, again, nothing wrong with a good old bread and butter breast augmentation that's very straightforward.
Right.
But that being said, some of those are really straightforward. And what you really want is a challenge
Right.
so that you can really take something and fix it and take care of it. It's really amazing. I mean, you love doing these complex cases. You love doing combination cases
Right.
all the time.
Yeah, it's fun. I mean, I think the biggest reason is it's actually a fun exercise. But I'm not gonna lie, the number one reason is that 3 to 6 month follow up, and they're just happy and strutting around and wanting to give you a hug. I think that's really reaffirms kind of why and what we do.
And don't you always encourage patients to go get second and third opinions?
Yeah. Definitely, I think it's always important, and I think there was too often where you would just kind of first thing you see, you do, and you move forward and kind of follow someone's lead. I think we've gotten better about having them actively engage in that process, and I think it's better. I really like that. Even when we know kind of what we think a patient should do, it's almost better to kind of introduce concepts, make sure they do diligence on it, and then come back and select that. That's a lot better. And I think selfishly for us, the biggest thing is we don't want to have to do unplanned reoperation on a patient. Not because we don't want to, we just don't want that patient to have to undergo that extra intervention. And that's really contracted significantly.
What do you see the role of fat grafting in the future and what's happening now versus what patients are looking for?
I think that it is fat grafting continues to be a really great tool. And I think the biggest limitation is getting the enhancement and getting the change that a patient wants in a single setting. I do think at some point in the future, we're going to be able to do that. We're going to be able to potentially utilize their own tissues, create a construct or an infrastructure or something that is like temporary that tissues grow into. It's a ways away. But I do think that our ability to get more predictability with fat grafting and doing things to get that volume to where one day, you won't have to consider an implant. But I think it's going to be a transition. I think maybe we're going to use more fat grafting along with smaller implants, and then maybe back those implants out, get rid of them, and replace it with tissue. I think that's kind of this concept that does exist.
So what would you say then? Because you said that there are limitations with that fat grafting. What is the primary limitation that you would say that patients,
Yeah,
when they're thinking about fat grafting versus implant,
right.
to differentiate?
I think the biggest thing is a realistic expectation of what it's going to do. In our hands, we're talking half cup to a cup of enhancement of size change. And the biggest thing is how much of it's available to take and how much that breast is available to withstand. And we always say when we give talks, it's a gentle balance between the availability of the donor site and the tolerance of the recipient site. So I think that's the biggest thing. What about you?
I like to tell them that they're not going to get that structural volume.
Yeah.
With fat grafting. Yeah, we can help with contour issues. We can help volumize the breast to about half a cup to a cup size, but you're not going to get that structural fullness. And a lot of the patients come in hoping that fat grafting will give them that rounded upper pole or that cleavage they want. And unfortunately, it's not there yet. Maybe in the future, to your point.
Maybe in the future.
But that combination of maybe some core projection with a small implant and then topping it off with fat grafting can achieve both.
Yep. And there's some things on the market now where there's essentially this concept of off-the-shelf kind of fat or allo-fat, which is fat that's kind of taken from cadavers and then treated or decellularized. They're already on the market, but there's new ones that are coming that some of our industry partners are working on where they're larger volumes. So it's almost essentially like it could become like a treatment, just like a filler. But again, there's a lot that needs to be done. When it comes to the breast, we're very sensitive about doing anything that could potentially cause an issue, so we need to make sure that these things are safe.
What do you see coming on the market with these newer implants that is going to be a key differentiator from the prior generation of implants?
Yeah, I think there's some interesting things that are coming down the pipeline. Where there's stuff that's been outside of the U.S. that's coming into the U.S. One of the concepts is new implants with a unique surface that is essentially a smooth surface that has a different kind of feel and behavior to where there is some level of micro, pseudo, nano texture to it that apparently stimulates a less of an inflammatory response. And so you're not going to get capsule formation. And that these gels are more viscoelastic. So the word that people use is biomimetic, meaning it behaves in more of a congruent fashion with the soft tissue, so it causes less inflammation. I think that's interesting. There are implants too that are outside the U.S. that are much lighter, where the fill is different. It's with these different kind of microspheres, so the density is less, so they literally weigh less. Those are going to be coming soon. And I think there's actually, there's been a situation where things have been kind of totally negated in the U.S. of no texture. Texture's bad. Where outside the U.S. texture is actually still used, and I think that technology is going to really advance because you and I are privy to some things that are available that are incredible. That are these concepts of textures you would never even see and feel, but they actually elicit different responses that are protective, that are almost bacteriostatic or cidal, and also limit the development of capsular contracture, or you could almost program the amount of capsule you develop. Like, say, I want a level 2, and I think that's kind of crazy.
It really is. I mean, and I think that's one of the beauties of us is like we here at HKB tout our horn for a second, but in essence, we're on these advisory boards. We're seeing what's out there, and we're going to be one of the first groups in the country to be able to get some of these newer devices.
Right. Well, it's important, right? I mean, the worst thing is just to do the same thing over and over again, and you got to advance it. Well, I think we got to get back to work.
Yep.
All right, guys. Take care.